So I think we'll get started on time and also know that this is being recorded for those of you who can't stay for the whole thing or would like to review this later. I'd like to welcome everybody to our second in our Hodgkin lymphoma series for WiLing Wednesday. For those of you who are not familiar with Women in Lymphoma, we are an international group committed to supporting and advocating for greater leadership of women in lymphoma globally through advocacy, networking, and education. Our chair is Professor Judith Trotman from Australia. We are also grateful for the support of the Snowdown Foundation and for Anna Steiner for her outstanding help in getting us organized and putting this on today. This is our second series after a very successful series on diffuse large B-cell lymphoma in the fall. So it's really an honor to introduce our speakers today who will be speaking on advances in radiation oncology. We have two real leaders in the field, not only in radiation oncology and in lymphoma, but in their mentorship of junior faculty. And they're going to talk about both of these topics today, and I'm really looking forward to hearing them speak. Our speakers are Dr. Mary Gospodarowicz. She is at the Princess Margaret Cancer Center in Toronto, where she is an emeritus scientist. She is a professor in the Department of Radiation Oncology. She graduated from the University of Toronto and has served as the past medical director of the Princess Margaret Cancer Center, the Union for International Cancer Control, the Canadian Association of Radiation Oncology, and the Canadian Committee on Cancer Staging. Her work has been really pivotal in the field with her interest in precision radiation therapy, looking at prognostic factor classification and cancer control. Currently, she's working on studies of image-guided precision radiotherapy and the application of modern information and communication technologies across different types of cancers. And she has had a long-standing interest in classification and emphasis on staging and prognostic factors. Our second speaker is Dr. Bouthaina Dabaja. She is the professor and section chief of hematology and director of research at the International Lymphoma Radiation Oncology Group and is at MD Anderson Cancer Center. She received her medical doctorate at the Lebanese University and completed her clinical residencies at the American University of Beirut and then at the University of Texas MD Anderson Cancer Center, where she is now. Her primary clinical goal is patient care with an emphasis on maintaining and improving cure rates in patients with lymphoma while decreasing short and long-term effects of treatment strategies, and has been extensively involved in clinical trials to move the field forward. She is also a member of the Lymphoma Steering Committee from 2006 to the present and was recently awarded Educator of the Quarter at MD Anderson Cancer Center. The topic of their joint talk today is radiation in Hodgkin lymphoma, a showcase of an ideal therapeutic ratio. We will stop for questions at the end, but please feel free to put any questions or comments into the question and answer. So with that,
thank you.
Hand it over.
So thanks. My name is Mary Gospodarowicz. I just got introduced. So I thought that what we will do with the session today is, first of all, I'll tell you a little bit of what Bouthaina and I will cover and basically introduce the subject, and also tell you a little bit about Bouthaina's leadership role in radiation oncology of hematological malignancies. And then she will present her work on modern radiotherapy in Hodgkin's lymphoma, which is our main subject. Then we'll manage some questions and then introduce our younger colleagues who are entering the field, and some of them are already leaders in the field. So this is a second session on Hodgkin's, and we wanted to discuss the use of modern radiotherapy technology in lymphomas and Hodgkin's. As you all know, radiotherapy is a seasoned and proven treatment modality. However, in the last probably 20 or so years, the delivery of radiotherapy has drastically changed. And at the beginning of the revolution in radiotherapy technology, the changes were mostly implemented in solid tumors. And the reason is because solid tumors require much higher doses of radiotherapy than are used in hematologic malignancies. So in many centers, the implementation of precision radiotherapy lagged behind in hematologic malignancies. And, you know, most of the literature refers to the issues of selection of treatment modality and when to use radiotherapy, and very often even in reviews or book chapters, the mention is, yes, the radiotherapy is useful, very often mentions the dose, but there's very little attention paid actually of how to do it. What's the appropriate implementation of radiotherapy plan? And it was noticed in about 15 years ago that the implementation of precision radiotherapy, modern radiotherapy in community lagged behind. And in 2010, Ahi Yahalom from Memorial and Lina Speck from Denmark, together with Bouthaina, founded the International Lymphoma Radiation Oncology Group. And Bouthaina had a major role not only in creating ILROG, but also in developing ILROG's academic agenda and growing the organization, providing educational activities, but also developing guidelines. And a number of guidelines of the utilization of radiotherapy of both Hodgkin's and lymphoma have been published in the International Journal of Radiation Oncology. And it's actually, those papers have been one of the most downloaded papers from the Red Journal, which shows the need for educating our community about proper application of radiotherapy in hematological malignancies. So you know about Dana's role in MD Anderson Hospital, but what wasn't mentioned is that actually she's trained both in hematology and in radiation oncology. So she has experience with systemic therapy as well as radiotherapy, which that really helps very much if your area of expertise and area of work is radiotherapy of hematologic malignancies. In fact, both of us have internal medicine and medical oncology training. It helps in increasing your credibility, but also in proper application of our modalities. And that's where, you know, in Europe and some other countries, there is a category of specialty called clinical oncology. And clinical oncologists actually are trained to do both systemic therapy and radiotherapy. And to a certain extent in hematologic malignancies, they have an edge because you don't have to convince your colleague either to use radiotherapy or chemotherapy, you can do it yourself. So it gives them some inherent advantage. And I think that in our mentorship and leadership of younger colleagues, first of all, we both believe that if you're going to practice radiotherapy in hematological malignancies, you should have not only expertise in application of radiotherapy, but also depth of expertise and knowledge of management of hematologic malignancies, especially Hodgkin's. That means that intimate knowledge of systemic therapies, management of recurrent disease, and so on. So what I will do is pass on the baton to Bouthaina, who's just going to tell you what we do right now, and then we'll take the questions. So over to you, Bouthaina.
Okay, thank you so much. I have to first thank you for inviting me. It's such an honor to be invited to this. But I have to say that I'm so happily surprised with what Mary said about me. When she was talking, my heart was beating very hard because I always looked up to her and her mentorship. She's a giant in our field, and just sit down here and listen to her talking about me like this, it's an absolute honor, no doubt. I'm going to share with you my presentation. Hope you can see my slides. And what I'm going to do is go through some of the modern development in the field of Hodgkin, but really it's not necessarily only for Hodgkin, it's just a showcase because Hodgkin is the most classic disease that we always basically debate about or wonder about the role of each modality in it. At some point, I'm going to talk about my mentees, but I cannot start my presentation without mentioning them, because the work that you will see wouldn't have happened without them. These are very successful, amazing women. They will be leaders in the field, no doubt. You know, many of them. They're extremely successful women. They deal with more than 110 hematologists, which is by itself telling. They increase the number of patients that we see. They publish, they get grants, they educate, and they are amazing mothers. We have 14 kids in total in our section. And one thing I always told them, that you are an oncologist, you're not a radiation therapist, which means you will decide when it makes sense to give radiation and when it doesn't. And you really should know as much as your medical oncologist would know about each case before moving forward to treat. So that's the overarching message and vision for our team. You might wonder at the end, and I will tell you the story, why is it they're all women? And I will be happy to share this with you at the very end, but it has to do with the secret recipe of hematology. Many people are not interested in hematology because it takes a lot of time, effort, and commitment from a radiation oncologist. What I will start with is that there is a renewed role for radiation. And I do think about it in the future, we will have a role, but it will be completely different than what we've seen in the past 20 years, even with the improvement that we made. And that role comes from, we have to change our mentality or our philosophy in looking at diseases. There is no doubt we improved survival across hematological malignancies with multiple chemotherapy, multiple immunotherapy, cellular therapy, and transplant. So therefore, it is not the rule of all or none. It's not that we cure the patient or we don't cure the patients. Many of the diseases have transformed into some sort of a chronic disease where at each time the patient would fail, they would come to you and you would treat them either with chemotherapy or immunotherapy, or even give them radiation. And that gave us the opportunity as radiation oncologists to bridge to the next therapy, to stimulate the immune system, which is the most exciting part of radiation right now. So previous therapy are associated with side effects. Therefore, whenever you give radiation, you have to be super thoughtful about how to give the radiation. And that's going to be the mainstay of the talk that I'm going to give today. There are major development that has happened in the field. First, the field reduction, and second, the dose reduction, and third, the versatile role that radiation can play even today. So I will go through it through the lecture. As Mary mentioned, in 2012, when we actually publicly formed the committee to start the guidelines, we met in the HODGKIN's Museum in London. And these are the photos that you see around where we were sitting in the meeting. And you could see how HODGKIN is really a disease not like any other. And obviously we came a long way. These are the pictures of the patients that the physicians or surgeons from England used to travel all the way to China without anesthesia. That's what I've been told. And they would operate on them to take care of their HODGKINs. Now, at the time when we don't do any more surgery, then radiation became such an amazing modality, because now you don't have to operate on somebody without surgery. Therefore, it became the next available best tool to address these patients. And what I did with this is I took a patient's CT and I put the old fields on it just to reflect to you with colorful lines what would look like when you gave radiation therapy back in the 50s and 60s to a patient with Hodgkin's lymphoma. And as you can see, you practically include the whole marrow. What we know right now is absolutely like 70% of their marrow included in the field, which would definitely lead to MDS, and a good portion of the heart, and obviously the spleen. And that resulted in all the papers that we all know about. that there is a secondary malignancy, there is cardiac events, and it's no surprise that these things did happen or these side effects did happen. I'm not a big fan of SEER data, but there are many SEER data that came from maybe the frustration of radiation oncologists that let's not completely throw away radiation because there is a modern development right now. These studies, they just show that you have a slight and a modest improvement with radiation therapy, and you don't want to completely throw it away. It's just that you need to renovate the role of radiation. So this is my favorite slide. I came up with it maybe 3-4 years ago when I realized, as Mary said, I trained in medical oncology at MD Anderson. So when I did radiation oncology, I really understood where a medical oncologist would come from. As a matter of fact, when I came to radiation oncology, I didn't know anything about radiation whatsoever. So I had really the mentality of a medical oncologist, just give radiation. I have no idea how you give it. So then I decided that in a given disease, if chemotherapy can give you a cure of 70 to 85%, then it makes sense to talk about the risks of it because you're offering the cure. But when radiation, in most cases, will give you a cure of 5 to 7% or attribute or contribute to the cure of 5 to 7%, then the side effects associated with the radiation should really match. And that was what led to all of what I'm going to show you right now. You've seen the slides from many people where we went from the total lymphoid irradiation, which is the hash diagram right there, to what we call today INRT or ISRT, which is involved site radiation therapy or involved nodal radiation therapy. This wouldn't have been possible without technology and computer. So this is the old way. You would have a chest x-ray, you would draw with a wax pencil on the chest x-ray, and then that's how you treat the patient. Down here is what actually that means in modern terms, that you would end up treating the whole heart, both axilla, all the way up to the neck. This is a courtesy of Dr. Eng, who gave me this, and it's just to reflect to you what we used to do versus what we do right now. In a nutshell, what IMRT is, or intensity modulated radiation therapy, is if I have a tumor on the left that I want to treat with the old method, then you come front and back, and everything in the path and in the exit will get the full dose of radiation, which is red here. While with IMRT, I could deliver the dose that is desired to the tumor while avoiding the rest of the organs around. So give you a practical example. I have this mass in the mediastinum. This is the left main coronary artery that sits right there. The patient showed up, I need to give radiation. The very first thing that I do when I look at the CT is, how is it I'm going to be able to avoid that coronary vessel? I'm not thinking how is it that I'm going to target this mass. The first thing I'm thinking about, how is it that I'm going to avoid the left coronary vessel? And there are multiple things that also we think about. I want to avoid the breasts in a young woman up to 35, and I want to avoid the lungs, because the lungs, as I will show you later on, they are the recipient of many chemotoxic therapy. So then eventually what you end up with is this kind of a radiation where you see it in the red line that ends up in an area that I'm interested in. The purple is your coronary vessels, and the green line is the lowest dose of radiation. So you could see one way or another, you were able to target the area you're interested in with avoiding the coronary vessels. And the way you do it is you actually switching from what we call the drawing on an X-ray to introducing CT scan in our planning. That was the first revolution that happened to us. Having computer planning will create a three-dimensional image, so it's a better visualization of what you're doing. But the most important thing is introducing computer modeling into the planning, in a sense that I have a target and I have an area that I want to avoid treating, then you enter it as a problem into the computer modeling, and with some mathematical iteration, you come up with a solution, or the computer will give you a solution, and that's how you end up targeting the area you're interested in, but avoiding the area you're interested in avoiding. But everything that looks beautiful on the computer has to be verified on daily basis. And that's why you see here an example of a machine that has a linear accelerator on one side, a CT scan on the other side, where the patient every single day, they would lie down here, you would scan them, re-image or insert the planning that you decided to do on that particular day CT scan, look at it, see if you like it, and then proceed with the treatment. Dr. Hudson's from Mary's group, David, did this paper that we all love, showing that it does make sense to decrease the field of radiation therapy. And when you do that, you do decrease the risk of breast cancer and heart failure. But the reason I presented to you those few slides that right now or before now is to show you that it is impossible for you to decrease the field without the use of technology. Because if you go smaller, then you need precision therapy, and the precision therapy cannot be done except with three-dimensional or a computer planning. So how do you implement the technology, which is a necessity? As Mary mentioned, this is when we met in the HODGKIN's Museum and came up with the new guidelines. And since then, as you can see, there are multiple guidelines that has been published in major venues. And the role or the purpose of these guidelines is to educate the radiation oncologists around the nation and around the world on how to deliver radiation therapy. Now, you would say that my radiation oncologists are very sophisticated. They have the most recent machines. Why would I care to educate them? Because remember that most radiation oncologists around the world, they do not see hematological malignancies, and they try to borrow all the knowledge from solid tumors and dump it into hematological malignancies. They think that more is better, and they think that they have a major role to play in hematological malignancies like they do in solid tumors, which is not the case at all. So you're not only educating them on how to implement technology, you're actually educating them on the disease itself. In a regular day of a radiation oncologist, there is a lot that goes behind the scene, very tedious work. For example, if I want to treat the mediastinum, I will go ahead of time, use this published atlas on the CT scan to figure out where are the left coronary artery, right coronary artery, the esophagus, the left ventricle, right ventricle, and so on and so forth. Because whenever I deposit my dose, I want to see each one of these substructures, how much did it get at the end of the day. We also use what we call breath hold. It is simply holding everything in space. Instead of going up and down with the breathing, you're just hold it in space, which will allow you to decrease your margins or to decrease your field of radiation. So again, what we're trying to show you here is, yes, I want to decrease the field, but to be precise, these are the measures that I have to take. And a quick look at both with breath hold, without breath hold, you can see how the whole anatomy actually does change. And this is a courtesy of Dr. Mikhail from St. Thomas and Guy in London, where he showed or superimposed the breath hold without breath hold, and you can see the difference in both of these. In a nutshell, when the patient comes to me, I put them on this inclined board, and what is meant to do, if you go down below and you see the same slice with the board and without the board, you can see how I eliminated the breasts from my field, because this is the PET scan when the patient is lying flat, and you can see the breast right there next to where I was going to target, and with the board where the breasts are nowhere to be found. And that's how I avoid the breasts. I use the breath hold as we talked. And because we talked about computer planning, that computer planning should not be mindless. Yes, the computer can give me solutions, But then in every single case, you as a radiation oncologist, and while talking to the medical oncologist, you know exactly which area you wanna go after. What is your priority? My priority is quite often avoiding the coronary vessels, the left main, the heart, as left ventricle, and the lungs. So therefore, although I'm using a mathematical isolation that would give me or produce solutions, I would go personally and interfere with these solutions to eventually come up with a solution that makes sense for me. And that's why the butterfly technique or the rainbow technique came from us and from our colleagues in Turin in Italy. Just to show you that when we do the planning, it takes a long time to figure out the patient in the same position and make sure that they hold their breath the right way. And this has become almost standard around the nation and many places around the world where they treat hematological malignancies, where they use breath hold. This is not to make you dizzy. It's just to show you that slice by slice, I go into the simulation, which is on the far left, compare it to the diagnostic CT, which is in the middle, to the PET scan, which is on the right, in each one of these panels, and I try to say which area I'm going to be targeting. The red is where I'm trying to target, and it will show you that it is not a mindless process. It's very tedious, and it goes slice by slice to figure out eventually and determine what my target is. When you talk about IMRT, they're like leaves that opens and close exactly how the mathematical solution came up with step by step how they should open and close to eventually give you this beautiful plan, for example, on the neck. And the reason this is beautiful, because the teal color here is the salivary glands on both right and left, pink and teal. And as you can see, the green line here is the lowest dose of radiation that completely avoided the salivary glands. Part of why I show this, because one of my medical oncology colleagues that actually trained with him in medical oncology used to tease me all the time in the multidisciplinary clinic, and he would say, well, Bouthaina, when you're going to give them radiation, they're going to come with a dry mouth. And I decided to always show this slide to show my colleague that no, they're not going to come with a dry mouth if you know how to deliver the treatment. This is another cartoon of how it should look like. The red line is, for example, chasing the mediastinal mass all the way down to the right side, which sometimes you see it a lot in primary mediastinal lymphoma. And to show you the green line, which is the lowest dose, we call it the 5 gray line, how it is totally avoiding the left ventricle. And what you see here in green is the LAD, which is the left coronary vessels, that is also off. And when you look at the breast, actually, they're not getting neither a low dose nor a high dose, which we are aware of, that even a low dose or a scattered dose of radiation to the breast in a young female actually would produce secondary malignancies. I'm not going to talk much about proton, but I know that this is a very hot topic to many people. And whenever it comes to talking about proton, I want you also to be aware that proton is a machine, but it really depends on the operator and the knowledge that a radiation oncologist should have when it comes to proton. And very briefly, I will touch on a few things. The first one is proton is a density dependent. From your high school knowledge, probably you do remember that proton is heavier than photon. So therefore, when it goes inside the body, it changes, moving from air, tissue to bone. And what that means, that the RBE, which is the effective biological dose or radiobiological effectiveness of the radiation dose, depends heavily on where that proton is going and what is it that is going through. So coming back to this very practical example, if I am using proton and you look at this orangey line here or orangey cloud here, and you look at the green area here, which is a coronary vessel. you would think that, okay, you're treating the mediastinum for me, you're avoiding the coronary vessels, I'm very happy with that. But then in reality, this is the most dangerous plan that you would end up with as a radiation oncologist. Part of the reason is because proton is a heavy particle. When it stops abruptly and it deposits all the dose right there. So what you think is 1 gray, it could be 2 gray or 3 grays. So therefore, we actually reject a plan like this, because what is going to end up happening, most of your radiobiological dose is going to end up right there in the coronary, and you move it further away from the coronaries, because that's the only way you could guarantee that your coronary vessel is going to be safe. You don't need to be expert in proton. You just need to be aware that it needs expertise when proton is given, and you cannot depend on the machine. You have to depend on the expertise of the radiation oncologist. These are studies that I like to show that came from Memorial Sloan Kettering, where they show you that at the edge of the beam, the dose actually could be twice or 3 times, or even sometimes 4 times in animal models at the edge of the beam from proton. So therefore, although we think of proton as a safe modality, and it is good to avoid side effects, but if not used correctly at the edge of the field where you have a critical organ, the very same organ you're trying to save, you can actually end up giving it more. And to mitigate this kind of lack in knowledge in the community, especially when proton became available 4 or 5 years ago, and there was a fever about it and applying it, we actually published in Blood our guidelines showing what are the scenarios that make sense to use proton, and when is not worth it for that patient to make the extra trip to another state, sell their house to get the proton. Now, how do we mitigate the normal organ toxicity? Did we look at that? And we sure did. My group, Dr. Penix, published what we call a nomogram. And in that nomogram, she looked at what is the chance of causing radiation pneumonitis in the patients that we treat. And in that nomogram, you give basically scores to many factors, including bleomycin or not, transplant or not, how many previous regimens the patient got, and also what dose you're allowed to give. And whenever you collect a certain number of factors, let's say bleomycin plus gem-bumel as a conditioning regimen prior to transplant, or melphalan, for example, then in that case, you are going to be more careful about the pneumonitis than worry at that moment about the secondary malignancy to the breast, because the patient is really in need for that radiation and in need of avoiding a toxic or a fatal side effects. We do not use the solid tumors criteria. As probably you worked with a lot of radiation oncologists, they always have these chit-chat paper or book that they go by, which is the kidney can take this, the heart can take this, and so on and so forth. I basically throw all of these in the garbage, and I tell my team, no, we have to go with the lowest possible dose ever, to a point that our planners, we call them dosimetrists, I always tell my team, give them the impossible so they would give you the most possible. Because if you tell your dosimetrist, it's okay for the heart to get a 15 gray, that's what they're gonna give you. They're gonna give you a plan that will give the heart 15 gray. But if you tell the dosimetrist, I want only 2 gray to the heart, it is impossible. The first time they're gonna look at you and say, what are you talking about? But they keep working towards it. And eventually now we do have these plans where we really follow this paper that was published in pediatric patients, where you have to give less than 5 gray. I love this paper by our colleagues, Maya Moraldo from Lena Specht's group. She published this to show that I always tell my colleague, please don't give one more cycle of adriamycin 50 milligram per meter square to avoid the radiation, because I will avoid the that extra 5 gray that is going to go to the heart for you. I'll do it for you. Just don't go one more cycle of chemotherapy. And what she did in that paper, Maya, is she showed that anytime you give an extra 50 milligram per meter square to the heart, as if you're giving a total of 5 gray right there. I will move very quickly to show you the complicated cases that one would get and how you have to be thoughtful about it. This is a typical case that went through all of these regimens. It was a pediatric case. And eventually you would see the vinorelbine, the bendamustine, the brentuximab, the nivolumab, etc. When this case comes to us and when we're planning, we take an extra effort to really avoid the pneumonitis. And you can see here that I have to take into consideration the previous immunotherapy or chemotherapy that was given, treating the tumor as opposed to consolidation, where I'm really concentrating on the tumor, but at the same time, I'm reversing my priorities. Therefore, when I'm planning, I am very cautious about the lung dose here, where the green is the 5 gray, because remember, they've been through a lot of drugs that are lung toxic. It's not that I'm not going to take care of the breast. I will, but I will make it my priority for them not to end up with a pneumonitis. Therefore, the studies that I showed you at the beginning, which is using the nomogram for the lung, avoiding the heart, or avoiding second malignancies, they become in the reverse order, because my priorities in this case are going to be shifting, because now I'm dealing with the life or death of a patient versus do I give them radiation and give them that extra 5 to 7% in their cure, or give them the toxicity of the radiation. It is very hard to be a radiation oncologist for hematology, because you can never predict how the disease is going to come to you. It might come in this form or that form. It might come as 2 separate nodes, bulky disease here and there. So you see it all. Therefore, you really cannot apply a recipe. For all practical purposes, for you as a medical oncologist, whatever combination they're going to come in, if this is stage 2 unfavorable per the German HODGKIN, you will end up maybe giving them ABVD or maybe BCOP or add brentuximab. But for us, it really differ on how we're going to be moving forward with the treatment, depending where the site of the treatment. So sometimes we go crazy. For example, for this case, presented with the mass in the mediastinum and another one under the heart. And then I was thinking, okay, I have 2 options. Either ignore the one next to the heart, which I'm going to show you that we published a study on that, or stimulate the patient twice, bring the mask that we actually use to the brain and invent at that moment, put the mask that we keep their brain fixed with or their head fixed with, to put it on the breast, move the breast away from that area. So therefore, if you compare with and without a breath hold, here you can see the mass and here you cannot see the mass anymore. And what eventually we ended up doing, treating her with 2 plans, 2 setup. I was very much at the cross hair of my therapist, because they thought why this patient should take 2 hours on the table. But I ended up treating the mediastinum in a separate field than the one which is the small node that I was really chasing next to the heart right there. Now, you don't have to do that. And Andrew Worth and again, Dr. Penix from my group, when we were in one of the meetings in Turin in Italy, they came up with the idea, what if we look at all the cases that we actually omitted that node and see what happened to them? And the reality is, you can sometimes omit, and you all see it quite often in your practice, that when the node is that small, probably chemotherapy will take a very good care of it, because there is a good penetration of the chemotherapy in that area. So that was our explanation as to why maybe in a case like this, you don't chase the very last bit of the disease, because if you do so, you're going to produce more toxicity than actually benefit. And that's why they published the paper. In the paper also, they showed something like this, where if you have a mass that is that big, then it will be very hard to omit that mass. But then when you see a mass that small, then it makes sense to really not chase it. And that's where the multidisciplinary clinic comes between radiation oncologists, because none of these cases I would decide on it by myself. If I don't have the team that I have right now, where every case we discuss it together, then I would reach out to somebody else, 3 or 4 people from around the nation or around the world, and ask them, do you think this makes sense, or do you think it's too crazy? Before I end, I want to present to you 2 things very quickly that I'm super excited about. When I was invited to this talk, I knew that you want to hear about the radiation as we know about it, that we would sit in every debate and argue, should I give it to radiation? And you would say no, and then we bring all the UK rapid, HD6, H10, etc. Or when we talk about diffuse large B-cell lymphoma, we'll do the same thing. We've been doing this for 20, 30 years. And I decided today that I am done with this. I am moving forward with the vision that there is a new role for radiation and we need to use it. And it's a fantastic way of using it, which is bridging before CAR T cell. So this is what I present at our national meeting 2-3 months ago in the ASTRO meeting. And I presented on the role of radiation prior to CAR T or after CAR T. I promise I'm not gonna bore you with this, but it's gonna be just few slides. This is your typical patient that comes to the clinic with the diffuse large B-cell lymphoma. And big mass at the beginning, had a complete remission, then took APOC, then R-GEMOX. R-GEMOX, by the way, is a very fashionable regimen at MD Anderson. Then they're being prepared for the CAR T, and oops, they have all of this recurrence right there. So then we decided to give this patient radiation just to bridge them while they're waiting for their CAR T. So the only thing we addressed is what you see here and not what you see there. And that's what we did. We gave radiation, very quick course. Then they went to CAR T. But before going to CAR T, one thing that happened that is very intriguing, the patient kind of relapsed all around the radiation field, but eventually achieved the complete remission. That left us intrigued as, what did the radiation do? Some of us thought that because radiation can stimulate the immune system and increase the antigen presentation, maybe there has been a flare of the Tregs around the body, and that's why you see it there. And that's the reason for why eventually the patient went into a complete remission. And looking at the literature that has been very active over the past 2 to 3 years, we are actually thinking of an immunogenic cell death role for radiation therapy. And all comes from reducing the dose of radiation. So what radiation oncologists that deal with hematology has been doing for the past 30 years is exactly the answer to the immunogenic cell death. Do not treat hematological malignancies like you treat solid tumors. Do not give high dose, because that high dose is going to kill the good and the bad. And the immune system, the very same immune system that you're trying to stimulate with the low dose of radiation, when you keep going with radiation, you're going to actually kill it. And you could see that one of the most exciting part, that radiation actually has an anti-CD47, which is the do not eat me signal that is expressed on tumor. It has an effect on it. And the fact that we saw that there is a promotion of the phagocytosis and the tumor-derived antigens and the whole idea of antigen stimulation, we thought that now we can start using radiation prior to CAR T cell regimen, not only as we call bridging or to debulk, but actually to help that immune system. I'm not gonna also go through the details, but I want you to be aware that there are many publications that are coming right now showing how when you give the radiation, the tumor cell mass goes down. You initiate a cell death with the very same cytokines that you're looking for when you use the CAR T cell. In some of the published Zuma trials and Juliet trials, there was some role for radiation that has been used, but it was not at that time with the knowledge that that's what radiation can do. At this point, we're only thinking and proving that at least in animal model, we need a low dose of radiation up to only 15 gray to do so, because if you go higher, then you will offset it by the high dose of radiation that will increase the Treg representation. This is 2 papers that came from my institution and from Memorial Sloan Kettering, talking about the role of radiation in CAR T-cell therapy. Many animal trials looking at the timing on where to give radiation to make sure that the microenvironment, it did not reset back. And I gave my first post-CAR T radiation to one of the patients also, and did not affect their T-cell expansion. So we're looking at that at the same time. The last thing is we went really big on the role of radiation, and now I'm part of the leukemia spore, where we are looking at giving an ultra low dose of radiation to our patients prior to checkpoint inhibitors to see what kind of an antigen presentation we can see. We just got this approved, and we're hoping that we can show you some of these results in the next 2 years. I am going to end up with this fantastic pain of one of my patients who had mycosis fungoides, and he got every single salvage regimen under the sun. And eventually he was going to be airlifted to where he comes from in Honduras. And his mother called me to tell me, if this was your son, wouldn't you have given him something? So I figured, okay, I'm gonna go against all the decision from the ethical group and give him total skin irradiation. And I did. And it took me 9 weeks to literally paint the radiation dose over his skin. The man had to take anesthesia for the first 2-3 weeks that I was treating him. Every single day they would bring him. This has been 5 years since then. Now he's a painter, and every few paints, I ask him to give me one of them, and this is his latest one. And he actually came to my house fully masked, with his wife bringing me a cake just 2-3 months ago on Thanksgiving. So I would love to share this story just to tell you that our patients are really our inspiration, and they keep us real and human. Thank you so much for giving me the opportunity to be with you.
Thanks, Bouthaina. Do we have any questions? I may have one. You know, you're a very progressive adopter of new technologies, and you're a stickler for standards. How do you deal with the knowledge, or where we all know that high standard provided at MD Anderson in hematological malignancies, in radiotherapy hematological malignancies, may not be actually available everywhere? How do you educate the community?
Okay, so I think MD Anderson, thanks to MD Anderson and the way they decided to manage their enterprise over the past probably 8 years, is to have many satellites, but also many what we call network sites, where it will be that I will be dealing on a weekly basis, something like 22 to 25 centers where I educate them. I have to say that it takes a lot of my time, but I don't mind it at all. So quite often there will be some radiation oncologist somewhere, I don't know, I'm not going to mention the state, and then they would say, I want to treat this patient. What I actually do, I go on Zoom or FaceTime with them. I look at their contours with them, and I send them, I made small movies on how we treat, and I send them these movies and teach them how to do it. You might think that, well, how you're going to educate everyone? Eventually, because we live in a new era on how people learn these days. It's not 30 years or 20 years ago, or even 10 years ago. People learn with 2-3 minutes of video, and they're over connected. I'm active on Twitter, for example, and I only use Twitter to educate people. Whenever there is a paper, whenever there is a new technology or a result, I tweet it. And you would be surprised on how much the new generation learn from this kind of a modality. So yes, the meeting in the past used to be the mainstream to teach, but now there is a new modality that is available, which is quick Twitter, quick YouTube.
Okay, thanks. We actually have a couple of questions. So one question is from Manali Kamdar. CAR T products usually require a 14-day washout prior post-radiotherapy. Do you believe that is necessary?
I do not think so. And that was in the earlier trials, which now, thank God, it does not need to be there. In reality, those 14 days are the most crucial to give radiation. I skipped over the slides that does show that when you give radiation, you disrupt the microenvironment to present the antigens. But if you wait past 14 days from the time you gave radiation, the microenvironment actually reset itself back to normal. So if you want to give radiation, it has to be within 14 days.
And Anka Prika, my colleague, my boss, head of our lymphoma group, asked, can you give a high-level approach to whom you would consider for proton beam radiotherapy in Hodgkin's lymphoma and primary mediastinal B-cell lymphoma?
I would look at the case, and if the mass is above the pulmonary artery / coronaries, then there is no need for the proton in this case. If it is going on the right side of the heart, then both IMRT in the good hands, obviously, and proton would be the same. If the mass is going in front of the heart, then this is the only time that proton could be beneficial. Everything I said is contingent on the ability of the proton center to use breath hold, because we just published a paper showing that if you use proton without breath hold, then it would not be advantageous over IMRT.
Thank you. We said that we will introduce our younger colleagues. So I have one and you have five. So why don't I start? So
yes, go ahead.
Danielle,
I will stop sharing.
Can you unmute yourself and put the video on, Danielle? So there's Danielle. Danielle is a young radiation oncologist who trained at Princess Margaret, but also did MPH at Harvard and just completed Harkness Fellowship. And we have common passion for lymphoma, but also common passion for improving the outcomes in cancer globally. Danielle, do you want to say a few words about your interests just for a minute or so?
Sure. Hi, everyone. Thanks, Mary. So I'm, as Mary said, I'm a radiation oncologist at Princess Margaret, and I work with Anka, who's also on the call. We have a smaller lymphoma group than at MD Anderson, but I actually took over Mary's practice over the last year, so I have very, very big shoes to fill. I treat lymphoma and breast cancer, and as Mary mentioned, my background is in health policy and health economics, and I have an interest in questions around cost and quality and access, both in Canada and North America, and also globally, and how we improve access to cancer care for patients in different countries in the world.
Thank you, Danielle. So, you know, I'm still interested in lymphoma, I still do, but I closed my clinical practice and I focus now on global cancer work, mostly NGOs work, but also academic work. So over to you, Bouthaina. We have exactly 7 minutes for you to introduce your 5 stars.
I'm gonna go very fast. 5 stars. The first one is Dr. Chelsea Penix. Many of you do know her. She's actually now the program director of our residency program. She started with me in 2012. She published extensively on mitigating the side effects of radiation, and also she's interested in incorporating immunotherapy and radiation while she's working with Merck on a Pembro radiation therapy protocol right now. Dr. Jillian Gunther, she's very much interested in education, but also in skin lymphoma. She became the deputy director of the educational program at ILROG, and she transformed this platform because she's young and she knows all about, as I said, the YouTube, the small videos, the Twitter, and she is in touch with the upcoming generation residency to teach them. Dr. Penny Feng joined me a year and a half ago. And in addition to having 2 children in the meantime, in only a year and 8 months since she joined, she put together an umbrella protocol on the use of CAR T-cell therapy for going from myeloma to diffuse large B-cell to follicular to Hodgkin and T-cell lymphoma, and she's just finished it. Dr. Susan Wu, she worked with Joanna Yang in UCSF, and she joined me only 6 months ago, another stellar and a star. And Lauren Mayo just joined me right now. She's one of the faculty in the satellite, and she was interested in lymphoma, so she joined the family. One thing I want to tell you about all of these women is very few people. So starting back at the time, more than 10 years ago, I worked by myself a lot, and I had a lot of in and out physicians. Most of the men could not take it because this is a fast-paced service. You have to immediately answer to the consults by your medical oncologist, be ready to them, run to the clinic, see the patient, bring them down, wheel them if you want yourself, wheel the bed to the simulation, do everything, have a thrilled attitude about the fact that they are consulting you, which is not something that in general radiation oncologists would like, because the misconception about radiation oncologists that they are the 8 to 5 and the weekend off kind of people. But on my service, you're literally like you're running an emergency, a mini emergency room in oncology with all the CAR-T bridging, the transplant that we deal with, the salvage refractory, etc. And thanks to our medical oncologists, they did a fantastic job in adopting each one of them. And I have to tell you that each one of these women had a mentor in medical oncology that got us to where we are. They're amazing mothers. We have 14 kids. Our wall in the clinic has over like 100 pictures of small infants from the time they're born until now. And I'm so proud of them. And really, you're looking at the leaders of the future.
Bouthaina, we have one more question. We still have a few minutes from Astrid Pawlowski. If you decide to give radiotherapy in localized Hodgkin lymphoma, only in case of end of treatment PET positive, would you radiate only residual hypermetabolic lesion, or would you radiate all hypermetabolic lesions in diagnostic PET?
So I look at the original PET scan, and everything that responded to chemotherapy and got into CR, I would only give it 30 gray, and then I would go after the PET positive. But PET positive, it's a very wide term. Is it PET positive Duvel 5 that I don't need even to touch it and send it to the medical oncologist for salvage? Do I need to do a biopsy? Is it a Duvel 4 and it's a small lesion, or is it a Duvel 4 but a big lesion that I need a biopsy? So I never jump and start treating without really going into the details. What kind of a Duvel positivity is it?
Yes, my answer to Astrid was going to be, it depends how much chemotherapy you had up front and what was the original treatment plan.
Right.
Because, you know, PET positivity at the end may mean that you actually need to come back with systemic therapy, but it depends on the original scenario.
Mm-hmm.
So I'm going to turn it over back to Anne for any last minute directions.
Well, I would just like to say thank you so much. That was really inspiring, educational and inspiring at the end. And I love the approach, the collaboration. And I think that's something that really resonates with the whole women in lymphoma idea here. And the fact that you're so committed to educating others in the community who may not have the resources that you have. And I think the really creative ways of doing that are amazing. And you know, these teams of junior people you're mentoring, I mean, I think that's one of our most important jobs. And I think a lot of times that gets overlooked. You know, really incredibly impressive. And I love the CAR-T and the immunotherapy. I think just as you said, you know, things are really moving forward in a way that is just amazing. And I think we all look forward to more collaboration in the future. And hopefully you can see some of the comments in the chat. I think the steering committee is just, you know, blown away by this fantastic presentation. And I think we need to collaborate more.
Can I say one last thing?
Yes, please.
I get a lot of complaints from my chair that how come I only hire women? And I always tell him, I don't mean to hire women. It's just only the women that can multitask and get the job done.
Yeah, I mean, the proof is in the productivity, and we recognize these names and the work that they've done. And,
Yeah.
you know, just congratulations to both of you. You know, it's really been a
Thank
great
you.
session.
Thanks very much for inviting us, and it's always a pleasure to contribute. And you know, what I would like to see is, as we discuss management of other malignancies, to bring the multidisciplinary approach when optimal, and not necessarily think of radiotherapy as a sort of standalone business.
Right.
The technical business is standalone business, but management of disease business is not, right? We work very closely with our colleagues.
Yeah, and I'd love to the comment, Bouthaina, that you made saying, you know, if you didn't have this team, you would reach out to a number of other people to run the case by them. And I think that's what we do in, you know, I think that's what women do. I don't mean to be sexist here, but I think that's really a strength of, you know, how we work. And we do the same with Andrea Inc. You know, we're on the phone all the time and we're talking to our colleagues. And I think you really do the best by the patients by working together in this way. And this is just
That's what I tell
inspiring.
them all the time. It is not about us. It's really about the patient, because at the end of the day, you want to go home and think to yourself, I've done everything I can do for that patient. And me and you, and we dealt over a case that I never seen, and maybe you didn't see either, but then we both worked very hard for over a year.
Yeah, with a great outcome. And I think that's why, you know, that's the great part about this job. So
thank you so much for making this happen and giving women the voice to be who they are. This is a fantastic forum, and I'm super honored to be here and to be introduced by Mary. Absolutely.
Well, thank you again. And we'd also like to thank our sponsors for today, MSD and Roche, and tell you we have 3 more sessions next week. We have Kara Kelly and Nancy Bartlett who will be talking about pediatric and adult approaches and their work in the cooperative groups in the US. I think it's going to be another phenomenal talk. We're on a great roll. So thanks again. And we'll hopefully see you next week.
Thanks. Bye-bye.
Bye.
Bye.
Thank you so much. It was fantastic.